Hey, welcome everyone to this webinar. We're just going to get started in just a second. I'm Mitch Kamrava. Will be just kind of introducing Dr. Folkert, and he'll take over in just a second. So give us just a minute or so while people kind of log in, and then we'll go ahead and get started in just a second. I'm going to get started. Looks like some people are still logging on, but want to give the right amount of time to all of our speakers who took time out of their day to come and do this. So thank you in advance to all of the speakers and on behalf of the ABS for participating. Just a few kind of announcements. This is part of our Brachytherapy, Everything, Everywhere, All at Once series. It's really kind of been the brainchild of Mike Folkert. So thank you to Mike for conceiving of this and kind of pushing all this forward with these exciting topics. Today, we are focusing on CNS brachytherapy and intraoperative radiation therapy techniques. This series will continue with the next installment, if you will, on intravascular brachytherapy that will be taking place February 28th. Just also want to remind people of our upcoming ABS annual meeting that's going to be taking place in June 2023 in Vancouver. Registration will open the first week of March. We've got a really exciting program. I'm a bit biased as a scientific chair, but really great national and international speakers. I think you guys are really going to enjoy it. And just remember, we are still in renewal season for ABS membership. These webinars are part of kind of your membership in addition to the annual meeting and opportunities for mentorship. So we really encourage everyone to kind of sign up and be a member. And with that, I'm going to hand it over to Dr. Folkert to go ahead and introduce the panel and get going with the rest of the webinar. Thank you so much, Mike.
Well, thank you very much. And so again, welcome to the CNS brachytherapy session. This is a very particularly interesting session for me because this is one of the things that got me into radiation oncology to begin with. I was designing applicators for brain and spine back when I was still a physicist before I switched to the dark side of medicine. I mean, CNS brachytherapy, there's a lot of options available for us. We're going to cover several of them today. So I had started off with plaque brachytherapy for dural lesions, which is the sadly no longer available P32 plaque. But now, at our institution alone, we've got stranded seeds, 2 different compact accelerator systems working on the gamma tile as well, all of which you're going to hear more about today. And really deciding what works best for your team and most importantly for the patient can be quite complex. So today we'll be looking at these primarily from the clinical perspective. Later on this year, there's going to be another session on CNS brachytherapy that focuses more on the physicist perspective. And we really hope that this session sparked interest in developing programs at your institutions and offering patients these incredibly useful and effective treatments for controlling disease in the brain. We'll kind of go through each presenter individually, but the first presenter will be Dr. Wernicke. She's our clinical associate professor of radiation medicine at Northwell Health, the Lenox Hill Hospital, where she leads the brain and spine program. She trained at Thomas Jefferson, has pioneered implant-based approaches for brain metastases, and she'll be discussing stranded cesium techniques. So, Gabriella, if you want to take it away.
Thank you very much. I'm very honored to be here, and thank you, Mike, for inviting me to this very exciting venture. Thanks for pioneering it. Thank you, the American Brachytherapy Society, and I'm delighted to present on the stranded techniques. Just wanted to be sure you can see my screen.
Yep, coming through.
All right. So good morning, everyone. I will be discussing the stranded seed implant techniques for cesium-131 brachytherapy in brain tumors. As you can see, the logo, there are two logos here, one from Weill Cornell Medical College, where it all began, and now continuing at Northwell Health. So I will touch upon implantation of cesium in brain mets overview, its delivery in newly diagnosed setting as well as in salvage setting, briefly touch on high-grade gliomas and allow my colleagues to elaborate with gamma-tile and intraoperative, other intraoperative techniques in meningiomas. I will discuss quality of life, neurocognitive outcomes, and exposure and safety. As we know, the definite indications for surgery are large tumor size, mass effect, significant amount of edema, and requirement for pathologic confirmation of diagnosis. This table demonstrates the crude local control after a resection of a single large brain met, amounting to 60% at 1 year. And so to improve upon this crude local control, whole brain radiation was employed and brought it up to 86%. What about stereotactic radiosurgery to spare some of the toxicities associated with whole brain radiation? So the North Central Cancer Treatment Group prospective phase 3 randomized trial assessed postoperative surgical stereotactic radiosurgery and compared it to whole brain radiation for resected brain mets. And as a result of this study, SRS postoperatively was advised to be considered as one of the standards of care as a less toxic option and alternate to whole brain radiation in this patient population. So postoperative radiosurgical option is an excellent option. However, size matters. It turns out that in tumors size more than 3 centimeters, 1 year local recurrence rate is 40%. In contrast to smaller tumors. But even in tumors larger than 2 cm, at 2 years, there's a 49% of local recurrence. In fact, in one of the largest studies in the literature of 100 metastases of large, more than 3 centimeter brain mets resected, local control at 1 year was observed to be only 72%. So there is a need to explore other options to optimize tumor control. And so how to best manage surgically treated tumor bed is still a good question. Let's compare and contrast intraoperative brachytherapy with conventional therapy and teletherapy techniques. Intraoperative brachytherapy affords a patient 2 procedures in one setting. It's frameless. There's no time for tumor repopulation as radiation release is initiated immediately intraoperatively. It's not limited by base. It's not limited by shape or size of the surgical cavity. It affords excellent tumor control, and it's arguably the most conformal type of radiotherapy. There are different techniques to place radioactive isotopes into the surgical bed. Some are permanent implants with iodine, palladium, and cesium, and others are temporary implants. And the gliocyte system will be something that my colleague and friend, Dr. Schwartz, will discuss later on today. Let us examine the cesium radioisotope as compared to iodine and palladium. As you can see, highlighted in red, cesium-131 has very clear radiobiological and physical advantages over the other isotopes in terms of its high dose rate, very short half-life, and high mean energy. In fact, it takes roughly a month for 90% of the cesium-131 dose to be delivered to the surgical site. This is in contrast to iodine, which delivers only a third of the dose by 1 month and continues to deliver the dose even 3 months out. Therefore, systemic therapy can be started at 1 month. This is what a typical stranded cesium suture seed looks like. It's a 9-line suture with every 5 millimeter surgical cesium seed embedded. In gray is a inorganic substrate of cesium is depicted in this picture, encased in a titanium case with a gold X-ray marker to be visualized in the middle on the scans. Compared to other radioactive isotopes, cesium affords the most compact dose distribution. And cesium is depicted in gray, iodine in black. And we conducted a study looking at the amount of volume of radiation tissue exposed. And we found that with cesium-131, the mean volume of brain tissue exposed to radiation is significantly less than with iodine, which might lead to a diminished toxicity to the healthy brain tissue. And so after cesium-131 was cleared by FDA, with an incredible collaboration that led to a number of projects with Dr. Theodore Schwartz while at Cornell, we began our journey with cesium-131 program. Our first study was a prospective randomized trial, prospective phase 1/2 trial of use of intraoperative cesium brachytherapy in patients with newly diagnosed brain metastases. Based on our institutional nomogram, we were able to predict how many seeds we would need to order depending on the preoperative tumor size. And so this would be a typical order form that one would need to fill out to request the seeds from the Accelerator company, where the patient name is stated here, the date of the implant, the activity of the seed, the number of seeds requested, and one loose seed for calibration. As far as the technique of implantation is concerned, a neurosurgeon will resect the brain metastases. We will await pathologic confirmation of malignancy. Once confirmed, sutured strings would be layered in cavity in parallel tracks along the entire cavity, separated by about 7 to 10 millimeters in width. They will then be covered by Surgicel, and the cavity will be filled with T-seal to prevent the collapse. This is what the pictorial translates into the actual OR pictures. This is a resection cavity, seeds layered 7 to 10 millimeters apart in the suture strands, and then the surgical cavity and seeds covered by Surgicel and filled with fibrin glue. Why do we do what we do? This technique was mainly designed to prevent surgical cavity collapse. As you can see, in red are the forces aiming at cavity shrinkage. Once seeds are placed and the cavity is filled, the arrows in blue represent opposing forces to the cavity shrinkage. Within 48 hours, we perform a post-implant CT scan, which will ascertain the 80 gray cloud with the number of seeds placed all accounted for. This is 80 gray cloud. And so in this study, our patients had 100% local freedom from progression, resection cavity control. This is a typical preoperative image of a brain metastases, which subsequently was resected. Cesium seeds were placed. We look at it 5 months post-op. And another example, preoperative tumor, resection cavity with cesium post-operatively at 1 month, 3 months, and 5 months out. There were very few complications. We had one dural tear requiring reoperation at 1.2 months after the implant, which meant that all of the dose was already delivered to the resection cavity, 1 seizure, 1 infection, and 0 radiation necrosis. Well, how does this compare to the previously published literature with iodine-125, cesium's predecessor? Well, while some of the studies reported very good local control, the trouble with iodine was up to 26% risk of radiation necrosis. We had 0. And so to reiterate on our technique, we studied how our surgical technique influenced the resection cavity dynamics, but by studying the pre-op and post-operative series of MRIs, what we found was that the resection cavity shrinkage was much slower with our technique as opposed to virginal cavity that was preparing for SRS. So this is cesium and this is the SRS cavity and their dynamics at 1, 2, and 3 post-op MRs. Subsequently, we embarked on studying cesium implantation in large brain metastases and in a prospective trial of initial 46 patients, metastases greater than 2 cm, which were resected at a median follow-up of 12 months, 1 year. Local freedom from progression again was 100%. And again, there was no radiation necrosis. Subsequently, we embarked on studying patients for salvage, previously radiated patients with whole brain radiation, SRS, or combination thereof. And again, we saw a very good freedom from progression in terms of local control. As far as neurocognitive function and quality of life in patients, we reported that mini-mental status scores continue to improve at 4, 6, and 12 months in a statistically significant manner, and we're reaching statistical significance at 2 months. And to briefly touch on GBM and high-grade gliomas, these were heavily pretreated patients, many of them with prior several surgeries and several rounds of radiation therapy. And these patients at 9 months after cesium implantation had crude local control of 85%. What we did for radiation necrosis rescues, we used bevacizumab. And again, our patients did not have radiation necrosis at 9 months. What about the safety of the procedure with cesium 131? We studied radiation exposure and safety precautions following the implantation. And from the very beginning, if one were to measure radiation at 35 or 100 cm, so essentially arm's length, there was a negligible amount of radiation. And so the most radiation that one could get exposed to is really just by the surface of the implantation cavity. So it was very safe procedure, considering the minimal risk procedure to the staff and patient families. It became quite popular and a very successful program, which we're continuing now at Northwell. Future directions, there are ongoing prospective studies with GammaTile, which the inclusion criteria were taken from our initial prospective phase 1/2 trial, which we're very proud of. And with this, I thank you and I hand over the baton to the next presenter. Thank you for your attention.
Excellent. Thank you very much. Pardon me. So we'll be moving on next to Dr. Beckham. Dr. Beckham is an assistant professor of radiation oncology at the University of Texas MD Anderson Cancer Center. He trained at Memorial Sloan Kettering Cancer Center, my alma mater, as well. And oh, Gabriella, can you unshare your screen, please? Thank you. And he is an expert in the multidisciplinary management of oligometastatic disease, especially spine and brain lesions. And so he will be discussing GammaTile implant techniques. Yep, and your slides are coming up. Oh, you're still muted, sorry.
Man, you'd think after 3 years. How's that look?
It looks great. I do it every presentation. I do it at least once.
Yeah, I mean, I don't know what to say. Okay, so thank you for that kind introduction. Also for having me here to talk about evolution of Dr. Wernicke's work with cesium-131 implants using basically a product that's commercially available now known as GammaTile, which is basically collagen tile brachytherapy with cesium-131. So thanks for the introduction and some disclosures relevant to GT Medical Technologies. So just to sort of piggyback off the same isotope, GammaTile is basically a product that is sort of demonstrated here in a schematic and actual pictures of the product itself. So it's basically 4 cesium-131 seeds that are basically aligned in two rows of two seeds each within a Duragen matrix. So it's basically a dehydrated collagen. Duragen is a material neurosurgeons use all the time. And this is basically what it looks like. It's 20 by 20 by 4. So I tell patients it's about the size of a postage stamp. And it looks like this. There's a bumpy side and a smooth side to these tiles, and actually that's meaningful. The bumps help with adherence to the cavity, which we want. It also helps orient us to the fact that these are differentially spaced, basically. So you can see if you look at the picture on the side views that the actual sources are 3 millimeters away from the bumpy side, whereas they're 1 millimeter away from the smooth side, which is something we think we take advantage of in terms of dose fall off rapidly with brachytherapy, creating a little bit of space between the surface of the cavity, which is basically normal brain, we hope, and the seeds hopefully reduces the risk of necrosis, which of course in experienced hands is excellent even without that spacing technique, as Dr. Wernicke mentioned. So there are FDA approvals for this product for recurrent and newly diagnosed malignant brain tumors. I'll talk about sort of what situations we use GammaTile for, and where I think it's appropriate versus appropriate to study more before we take advantage of that FDA indication. Again, just a little bit more about this. So basically, I think one of the nice things about GammaTiles is that they're dosimetrically spaced. So it's basically designed such that if you tile side by side, that you end up delivering 60 gray physical dose to 5 millimeters depth. Don't ask me to do the calculation, but in BED terms, I've convinced myself that's pretty similar to 27/3, which is a pretty common adjuvant dose for brain metastases. So 27/3 to about 5 millimeters depth, which is, you can sort of backtrack and think of the actual surface of the cavity a little bit higher, which may be an advantage over standard postoperative radiosurgery in terms of getting a more effective dose at the surface of the cavity, which is going to have a higher risk of having, cancer cells left behind. In terms of how we actually procure these tiles, so GT Medical Technologies basically makes them, manufactures them, and then they're sterilized by a third party. You need about 4 or 5 business days prior to implant. I'm not sure if it's faster or shorter or longer, with a stranded seed technique. But basically, I like to have a full business week. Our physicists wish we had a month, but typically if we have 4 or 5 days notice and everybody's available, that usually works from identifying the patient, getting them consented, and then ordering the tiles to be ready for the surgery date. The half-life is 9.7 days, and these lose about 7% of their activity every 24 hours. So the OR date's important. We can't just do it a few days later. I sort of mentally rehearsed if we had to delay by a day, would I do the implant? And I think I probably would, but not much more than that. So the OR date's obviously, critical for, as with all short half-life isotopes. So in terms of the actual procedure, we estimate the tile order using a software you guys may be familiar with, MIM, contouring software. There are some plugins basically that help us estimate the surface area of the anticipated resection cavity and estimate the number of tiles we're going to need to cover it. And then there's some sort of fudge factor for experience if we expect it's going to be a cavity that contracts or if it's not. And then some discussion occasionally with the surgeon about what they think the cavity is going to end up looking like. We order the tiles before the implant. Our physicists receive the tiles and do QA on a seat, obviously. And then in terms of the OR day, the surgeon basically performs the resection. Occasionally I'll go and just watch, but more often than not, I'm in clinic or doing something else. And I request that they get frozen path for all cases, but more often than not, it doesn't happen. But certainly for previously irradiated cases, I sort of insist upon it just because we don't want to implant pure radiation necrosis. And then occasionally a patient's had a long interval between their prior cancer history and their brain metastasis diagnosis. Want to make sure we know what we're dealing with and don't inadvertently implant a glioblastoma, for example, which we've warded off a couple times by being aware of that possibility. So towards the end of the case, we basically come to the OR, a radiation oncologist, which is almost always myself, although we are expanding the number of rad oncs at MD Anderson who are doing this procedure. And then physics will go to the OR towards the end of the resection. We have a conversation about how it went in terms of the extent of resection. Is there any concern for residual disease? Are we close to any OARs? Of course, we know that from the pre-op imaging, but it's helpful to again discuss it and if there's any need to consider mitigation of dose to those structures. And then basically I scrub, I receive the tiles and prepare them in a sterile fashion and basically facilitate handoff to our neurosurgeon. On a smooth day, and usually they are pretty smooth, I'm in there for, 15 minutes or so, and then I go back to whatever my day is. One of our physicists obviously stays and does the survey after after the patient leaves the room. So appreciate them for doing that. And that's basically the procedure. We do post-implant dosimetry like Dr. Wernicke showed, and I'll show you a couple of examples, or at least one in a subsequent slide. But this is, I figured I owed you at least one bloody picture. So this is sort of what the resection cavity looks like once the tiles are implanted. So you can see we mark the smooth surface. So you can see that these are the tiles there with that blue marker. And basically we tile towards the bottom and try to get good coverage of the bottom with bumps to the brain. And the tiles basically approximating one another, ideally not overlapping because dose would build up, and then build out the edges. You can kind of see these are probably half tiles. You can cut them in half, or you can technically cut them in quarters if you wanted to, and sort of build up the edges of what we think is the at-risk tissue. And so that's what it looks like. So just to run through some of the data for gamma tile specifically, it's great to hear Dr. Wernicke's review of all of her wonderful work in sort of pioneering this. But for this product specifically, this is a report of the Barrow Neurologic Institute. Some of the founders of the company are authors on this study, looking at basically cesium-131 implants before they were probably called gamma tiles, because I don't think they were a commercial product at that time, but this was in the development of them in terms of suspending them within the collagen matrix. Looking at 20 recurrences, previously irradiated, previously operated in most cases, and kind of pretty heavily pretreated patients, several surgeries, if you can see in this column here, 1, 2, 3, sometimes 4 surgeries, multiple prior courses of radiation, including SRS, and some of them got IMRT, which is a little interesting looking at these data. I just realized this yesterday. They got a lot of prior radiation, but not that many of them got intensely modulated radiation therapy or sort of a comprehensive dose. A lot of them got radiosurgery. So keep that in mind. But the data, I think, are interesting and compelling, and sort of on the backs of this data, I think the FDA approval for recurrent lesions got granted. And so what they're looking at here is in pink, this is basically the progression-free survival, local progression of these lesions after gamma tile implantation in comparison to their prior therapy. Sort of an interesting way to present the data. I think it's an interesting one, but it sort of reflects the fact that these patients are recurring. They're recurring multiple times. Their interval to recurrence typically becomes shorter over time, and yet with the addition of cesium-131 tiles was better. Glioblastoma also has a pretty good paper out of the University of Minnesota for gamma tiles, Clark Chen's group. They implanted 22 recurrent GBMs in this study, 14 second, third, 8 recurrences. So these are patients that we're all familiar with. If you treat CNS, they're sort of coming back over and over. And occasionally, a subset of these patients continue to have a need for surgery, a need for local therapy. And they basically implanted these folks. And I think the take home, they have a lot of, molecular data, which is interesting for the paper itself. But the take home is their local control at 12 months was 81%. I think that's pretty good for glioblastoma. We don't always see that with, postoperative external beam radiation, even in the upfront setting. And their median overall survival was 20 months, which I think is extremely good. I think it reflects really well-selected patients and obviously excellent technique, because I don't think we can quite quote 20 months to a newly diagnosed glioblastoma with standard of care therapy. So pretty good outcomes from this. I think that more work needs to be done in terms of looking at the patterns of failure. They're not recurring locally, but where were these implanted cavities in relationship to their prior radiation, prior surgery, all things I think that come to mind when reading this paper. But I think promising initial results for the recurrent GBM setting. And then from MSK, Dr. Folkert, my alma mater, the Upper East Side of Manhattan, Sloan Kettering, put out a paper of some patients who had previously had radiosurgery for brain metastases, recurred, and then got surgery and implanted with gamma tile. So these are probably some of the patients that I learned how to do this procedure on. So it's nice to see this awesome report from my co-resident, Dr. Ember. So this is a report of 25 cavities implanted in 24 patients. And this is just the cumulative incidence of local failure, which was 8.4% at 12 months, which I think is very, very good. The MSK also has a paper for the patients that did not get to get gamma tile, just resection for recurrent disease, and they reported 40% local failure without any adjuvant radiation. So this is a population that, just like in the upfront setting, we know surgery is really not sufficient. There's a very high chance that they're going to recur. So they do need something additional, but we're always concerned about toxicity. So this report was of 16% rate of symptomatic necrosis. I think it was well controlled with steroids. So I think pretty favorable. Just anecdotally, we don't have a fully analyzed set of patients yet, but I haven't seen any radiation necrosis. Maybe one case, from our experience. So I think radiation necrosis rates are actually pretty low, and local controls obviously very, very favorable. So just sort of breeze through the types of patients we're implanting with GammaTile. And for radiation-naive brain metastases, I consider this a patient that we would enroll in a clinical trial. So, we're the lead institution for the ROAD study, which is a phase 3 randomized trial of GammaTile at the time of surgery versus standard of care post-operative SRS for surgical brain metastases. And so, for anybody with a radiation-naive brain met that needs surgery, we're trying to enroll them in this study, and appreciate the centers that are participating in the study for doing the same. Previously irradiated brain mets is basically what we do most of off study, and most of in general. And same with previously irradiated glioblastomas. We haven't done as many. These are probably pretty up-to-date numbers. Basically, in the re-irradiation setting, we want to be pretty confident that what we're seeing is recurrence, not necrosis. You probably all have your institutional protocols for how you do that. But if we're really suspicious of recurrence, and I'll give you some sort of things that I think about in terms of selecting patients, we often do GammaTile in those cases. And then we haven't done any previously irradiated meningiomas. I think that's sort of ironic because it's the earliest data for GammaTile, but we're always looking out for cases. So you can stop me if I run out of time. I'm not sure how much I have left, but should I keep going, Mike? Or?
You're doing okay. You're doing okay.
Okay. So I'll just tell you some of the things we think about in terms of case selection. So for previously irradiated brain metastases, just the ideal patient, in my opinion, is the one who has had a single prior course of SRS. They failed. We're not so enthusiastic about doing radiation again, yet we know they have a 40 to 50% chance of recurring in that cavity. So a patient had prior whole brain, I still think they have the opportunity for post-op SRS, and I would prefer that just because I think it's more standard of care, and we have pretty good data that got us to post-op SRS as a standard procedure for these patients. But the patient who's had multiple prior courses, you're going to start to get nervous about what is the true risk of necrosis, because the number of patients reported with this technique are still small, is still small. Obviously, you want a surgical candidate, so someone who's doing well, who has need for local control in this lesion, and that sort of reflects their intracranial disease burden. If they're going to need whole brain radiation anyway after surgery, I wouldn't recommend GammaTile, but if the surgical lesion is the dominant issue and you need local control there, you're going to be able to SRS the other lesions. Then I think in the recurrent setting, GammaTile is my standard of care. And then technical feasibility. Ideally you want a gross total resection. You don't want to be too close to optics or brainstem, but all those things can be thought about. So this is just an example. I think this is a really interesting case. I think if we get time to discuss the case that we submitted, I think this is a pretty cool one. This is a guy with lung cancer. He had this lesion and several others treated, I think, a couple years prior, but you can see on this image, this thick, nodular wall of enhancement. That's concerning, but we definitely get, perfusion parameters and spectroscopy to try to confirm that we think we're dealing with a viable tumor rather than, primarily necrosis. And there's a lot of perfusion there. So we took this guy and did a GammaTile, and it's an interesting tale if we get to it. So that's how we think about previously irradiated brain mets. For glioblastomas, I think it's similar concepts. I think the pattern of failure is really critical to think about. Is this a direct infield recurrence? Is it a marginal recurrence, or is it a totally new site? I was trained to believe that glioblastoma is a whole brain disease. So, recurrence can mean very different things depending on the patient. How they're doing, KPS, prognosis overall, very important to consider. As well as features that are prior radiation. I don't think there's any, I don't have any qualms about doing GammaTile directly within field of 60 gray and 30 fractions, which is what most of these patients have had. But you want to think about the time. That there's not much data for doing it prior, less than 6 months elapsed from prior radiation. So typically we'd like to see that. And then, again, with GBM, how local is the actual issue? I also think about whether or not they're methylated and whether or not they could get a repeat course of external beam with a Temodar rechallenge, because I think sometimes those patients, do pretty well with that, with fractionated radiation and covering a larger area with a radiosensitizer. So some of the things I think about for those cases. And here's just an example. This lady recurred directly in field, I think, 3 years after her initial surgery and radiation. We got an ABTI we call advanced brain tumor imaging. That's basically our fancy MRIs with spectroscopy and perfusion. Sometimes we think about FLAIR, whether or not the FLAIR actually represents infiltrative tumor versus edema. She had really a quiet FLAIR going on in her brain, but obvious nodular recurrence. So this is the dosimetry from our implant. Basically, just to highlight a couple of things, the pink shaded structure is our GTV. And then the 60 gray target, which again is our prescription goal, is represented by the thicker red line. So just an example of what the implantation looks like. So I think for non-previously irradiated lesions where there is a standard of care, patients should be enrolled on clinical trials. The ROAD study I mentioned briefly, we're randomizing between GammaTile and standard of care post-op SRS for previously untreated surgical brain mets. So thank you for thinking about the trial if you're participating. MSK has a randomized trial for GammaTile versus physician choice, which at MSK is usually observation for folks who get surgery for an SRS failure for brain metastases. So I think that's going to be a really interesting study to get some randomized data for this indication, which I think is a pretty good one. And then the Gestalt study, the GT MedTech is also funding, and we're trying to get it open here at some point for newly diagnosed glioblastomas. It's a single arm feasibility study, basically of using GammaTile as a surgical boost, so to speak, and getting the radiation started sooner with GammaTile in the cavity, and then doing adapted external beam radiation to sort of make up a similar to STOOP field, but incorporating brachytherapy. So that's my talk. I'll stop there. Mike, you're muted.
I even clicked the button for it too. Missed it. So keeping in mind that re-irradiation question, that's one of the things that came up in the Q&A. We'll talk a little bit more about how folks are taking that into account later. But that is definitely one of the hot topics of what we're trying to of how we interweave high dose external beam versus fractionated external beam versus single fraction intraoperative versus LDR intraoperative. So next up, we'll be hearing from Dr. Cifarelli, who's the Associate Professor of Neurosurgery and Radiation Oncology and the Director of the West Virginia University Gamma Knife Radiosurgery Program and their Brain Tumor Program. He's a recognized leader in intraoperative radiation therapy for CNS lesions and experienced program developer for multidisciplinary cancer care initiatives. And he will be discussing compact accelerator-based IORT techniques. And so I'll go ahead and take it away.
All right, well, thank you very much for that introduction. Let me share my screen here and make sure we have everything set up properly. I thank the ABS and Mike for inviting me to give this talk, which is near and dear to my heart. If you'd asked me 7 or 8 years ago when I first started down this path, if I'd be at this point still doing intraoperative radiotherapy, I don't know what my answer might be, but here we are. I do hail from the Rockefeller Neuroscience Institute at West Virginia University, where we're undertaking advancing radiation care for our patients. Here are my disclosures. We'll just go over the overview of topics, be fairly straightforward. We'll talk about the workflow for intracranial IORT, what's the clinical evidence to support IORT in gliomas or brain metastases, are there any safety or dosimetry concerns in those patients that you treat with IORT, and I'll just briefly touch on whether or not IORT has some advantages from a biological or value perspective, at least in our patient population. So this is a lot of debate in CNS radiation oncology and neurosurgical oncology, but one topic we can all agree on is that radiation plays a significant role in the management of all of our patients. And really, when it comes down to it, what we're studying from a clinical perspective, from clinical research, is more the timing and targeting parameters that can impact outcome, whether or not, there is no more debate as to whether or not we're delivering treatment to our patients. Dan Trifoletti and the group at Mayo Clinic have been looking at preoperative SRS for treatment of brain metastases as a theoretical and now a practical implication for some advantages that they felt were increased local control in the patients, decreased LMD, decreased incidence of radiation necrosis, but it's a double-edged sword in that if you're going to give preoperative SRS for brain metastases, you also lack pathological confirmation at the time of SRS. Although it's rare for us to be fooled, it does happen. So we felt that IORT around the time contemporaneously when Dan was putting this work together, we had started looking at IORT in our own program and felt that it had the potential to be even more effective in achieving some of these endpoints. So IORT is not a new concept, and I don't want to give the long history lesson, but these are things that have been around since the advent of the Curie's description of radium. Oscar Hirsch was using intranasal applicators to treat secretory adenomas in Austria in the early 1900s. Fraser at the University of Pennsylvania was using radium with some trepidation in the early 1910s. And Harvey Cushing, the father of all neurological surgery, was using radium bars put in a resection cavity at the time of surgery. And it described in this very nice historical treatment by Mike Schulder at Northwell. So there's been significant trial of radium use in short course after its initial characterization. But where do our modern treatments parallel in these early intraoperative radiotherapy or intracranial brachytherapy techniques? And really, if you look at Hirsch's applicator as it was placed temporarily in approximation with the tumor living in the cella, we see that more with the work of Reese Cosgrove, and I'll show this in a little more detail with the photon radiosurgery system, and then the modern incarnation of the applicator that we use in our practice for intraoperative radiotherapy with low energy X-ray. And there's a schematic from a review that we looked over all these techniques for IORT that Jerry Jacobson and I put out about 2 years ago now. So radiation delivery for IORT is really defined as a single anesthetic episode. So at the time the surgery is going on, you're delivering your full dose of radiation at that time. It's not going beyond the episode of anesthesia. And compare that to what Cushing was doing with radium bars, really is more akin to what we were just looking at with the gamma tile and intracranial brachytherapy in its truest sense with implantation of either the seated strands or the wafers. So where are we? The rest of the talk is going to talk about low energy X-ray, and just to give the nod to Reese Cosgrove and the group at Harvard in the late 90s, we wouldn't be here with IORT with the device that I use and that others use if this device did not exist. This is the photon radiosurgery system, a compact accelerator with a needle tip applicator. The concept here was simultaneous stereotactic biopsy and treatment without resection. And as most of you can probably assume, this didn't have the greatest of outcomes with even the smallest of metastatic lesions, because the dose drop-off rate was very, very steep, and the ability to actually drive the dose to the margin to be able to actually get an effective treatment was limited. The modern devices come in multiple flavors. On the left here is a device marketed by Zeiss called Intrabeam. On the right, a device marketed by Zoft. It's very similar concepts. You can see here the patient head is actually sitting under brass shielding. You have a multi-articulated arm with a spherical applicator that looks like an ice cream cone actually put down into the cavity. Here, this is a balloon-based catheter that I'll show you in a little more detail in just a second. But the idea is very different than what Reese Cosgrove had described. We're treating the cavity wall rather than primary tumor treatment. And here's what the spherical applicator that's rigid looks like in the device on the left. And then the balloon applicator, which is of course variable in volume, on the device on the right. What are the preoperative or intraoperative workflow factors for delivering intraoperative radiotherapy? And this is probably what I speak more on than anything else, is how do you actually do it? Patient selection is critical. This is not for every patient. I'd much rather have a bunch of different shaped hammers to hit different shaped nails than just one hammer trying to hit every nail. Surgery needs to be needed rather than just feasible. It's great to go after something like this that's right up on the surface, but this was a solitary brain lesion in a patient that had no extracranial disease of note on a scan. So we went ahead and it was a melanoma, and you can tell from gross imaging, it looks hemorrhagic, and it was a melanoma, and we needed to give this patient a diagnosis. The other thing you have to consider are the organs at risk. How close is your lesion of interest to the optic apparatus or brainstem? We'll go over some details of how to actually figure out what that OAR dose is. Standard operative tools that are available for everything, namely navigation with or without the microscope. I can't imagine a situation where somebody could effectively argue that they are going to do brain tumor resection on a metastatic lesion or a newly diagnosed glioblastoma or even recurrent glioblastoma, that they didn't at least utilize navigation. So we're not reinventing the process here. Patient positioning, the majority of my patients are supine or lateral. Prone is challenging with the device that I use, strictly because the articulations of the arm to get the applicator in with a true prone position patient for a posterior fossa med is quite difficult. So I cheat and put them in lateral and do 3/4 prone with the head turned to the floor. Resection technique, this is surgeon's choice. I prefer in block, but when I have a metastatic lesion that's 5 centimeters in maximal diameter, I can't really take that out in block in most cases without causing significant damage to the adjacent brain. So sometimes you do a piecemeal resection. The most important thing is really hemostasis and avoidance of the CSF space. If you get down to the ventricle, you have to repair CSF egress, because the key to this procedure is direct apposition of the applicator surface to the cavity wall. If there is a separation there, you're not going to get an effective dose. Specific procedures beyond those, here are 2 images. This is actually with the spherical applicator placed below the brain surface here and then connected to the machine up off the top of the image. And this is an image from my friend and colleague Brian Williams at the University of Louisville on the right, and he has the balloon-based applicator with the device that he utilizes in Louisville actually deployed, and he's filling it up by the syringe. So applicator sizing and balloon volume determination are really the specific procedures that go into this process. In this fixed applicators, they go anywhere, range anywhere from 1.5 to actually up to beyond 6 centimeters. We won't recommend going beyond 4 centimeters, and I'll talk about some of that data in just a second as to how we came to that limitation. The balloons can go from anywhere from 3 to 6. We do surface and cavitary measurements. I'll show you the very high-tech method I use to measure the surface and cavity dimensions. We do a trial placement with our spherical applicator. They do a similar trial placement with the balloon. When I mentioned re-sterilization without use, these are sterile prepped applicators. You can only sterilize them 100 times, so we don't break open every applicator and re-sterilize them every time for obvious cost reasons. Draping and insertion, it's basically the microscope technique in the operating room for the neurosurgeons in the audience, or those of you who have some experience in the OR. It's team-based. We do a little irrigation on the rigid applicator to make sure we minimize bleeding or disruption of the cavity wall. And then we do a shielding process where we basically, in our case, we put brass mesh on. This is a similar shielding apron that's placed over the top for the Zoff device. Do a room survey with the physicist, and then treatment times anywhere from 11 to 40 minutes. Organs at distance measurement, how do we actually do this? Well, I mentioned that intraoperative navigation is utilized for pretty much every case that I do. Here we use a tip extension device where we put the pointer down in the closest portion of the resection cavity to the metastatic lesion, or primary lesion or metastatic lesion, and then measure the distance to the optic apparatus or the brainstem, and then put that into our software system to make sure that our doses are within tolerance limits. Here's a brief video, and it's truncated for time. It's also sped up, so don't think I moved this quickly in the operating room. It's running at 1.5 speed. Here's my high-tech measuring device. This is a paper ruler cut to size. We measure surface, and then we measure cavity depth, and this gives me an idea, after I've removed the tumor, what size applicator is going to be the most appropriate, because there has been some decrease in size. Here we're measuring the organs at risk, so we're using the tip extender. Here we're putting in a trial applicator. Here's my resident with his trusty asepto irrigating for me, putting too much fluid down in the field. Now we want to make sure that we kind of figure out what the best trajectory of the applicator to reach the most surface area is. So I kind of memorized that position with the trial placement. Now you can see it's been draped off field with the applicator placed to the device, and I want to get it in that same position. So here the resident really likes his irrigation. And we'll aspirate some of that irrigation out and make sure the brain's relaxed around the outside of the applicator. And then we can go ahead and move to our shielding as our next process. So we start out with just a layer of wet lap sponges that go over the top. And then we'll end with our brass shielding, which will be coming up here in just a second. There we go. and then the room survey, and we're off to the races. So as I said, anywhere from 11.
I think we might have an internet interruption.
A 30 gray at the time of resection, followed by standard Stoop protocol, 60 gray of radiation. And what we ended up seeing was stable local enhancement around the resection cavity, but with remote progression. So sites out of the field for IORT, but certainly within field for their standard external beam radiotherapy. This led to the Intrago 2 study, which is currently open and recruiting. This is a phase 3 study comparing standard of care resection EBRT with concurrent temozolomide versus IORT boost with a preferred dose of 30 gray at the surface at the time. So really no delay in time to initiation of radiotherapy, which would be the standard. And we're still awaiting the outcome of this study. I will tell you that there has been a interim analysis done by Gustavo Soria, who's also with Frank at Mannheim. Actually, now I think he's currently in Bonn. And what was important to note here, since these patients all got 60 grays, commencing 3 to 4 weeks after they got 30 gray to the surface, was there was a significant incidence of radiation necrosis of 25% of the patients that were analyzed at this time. 18% of them were grade 3 SAEs. Which is not something to scoff at. But when you look at local progression-free survival rates in these patients, they range anywhere from 61 to 38% at 2 years. So it's promising. We still need to wait for the results of the clinical trial before any of us are willing to say that an upfront boost with IORT using low energy X-ray should be a standard in patients with newly diagnosed GBM, but that's why we do our clinical trials. Here's one image of an early outcome in a patient. This is a rare thing for me to have to reoperate on somebody after a surgical resection and IORT enrollment. As a young girl, 26 years old, IDH wild type GBM, had a large cystic lesion with a large solid component. We resected it, gave her gross total resection, gave her 30 gray at the surface. She came back with this sealed off cyst, and she was symptomatic from it with headache, no seizure. And then there was some nodularity in the posterior medial portion of the cavity. So we went back and actually lined up exactly with those spots. I took a total of 11 specimens and resected a little nodular area. Everything was radiation treatment effect. No viable tumor seen anywhere. Now we look at her 18 months later, we see progression just out of the field of the IORT along the septum pellucidum. So it's traveling on white matter tracks as we expect. This is about 6 months ago. We just saw her back at 24 months. Her KPS is still 100. She's living her life now with a GBM, but she's 24 months out. So there is something to being aggressive with these patients, I think. So once again, jury's still out. Where is IORT in metastatic disease? This is where I think we're gonna have the most impact. You've already seen Paul Brown studies looking at SRS being superior to whole brain for word recognition and neurocognition. What we don't always look at is this figure, and this is from his presentation at Astro before this came out in 2017. This is where whole brain radiotherapy was far superior to SRS in local control rates in these post-surgery SRS treatments. And why was that? Well, the trial was designed to de-escalate the dose. So when you had a volume of more than 2 by 2 by 2, which would be 8 cubic centimeters, you're down at 17 gray. And for those of us that do SRS on resection cavities, if this is really as low, 16 is as low as you want to go with the margin. So we de-escalated the dose, and in our mind, IORT could actually allow us to potentially escalate the dose and also eliminate time to initiation of therapy. So we started looking at this and did a dose escalation study that was published back in 2018, where we looked at the maximal dose to the brainstem and the optic apparatus, comparing our gamma knife treated patients to IORT treated patients with theoretical doses of 30 gray at the surface, and found that where our normal dose laid anywhere from 15 to 20 gray at the margin. We were always in a better situation with 30 gray delivered to the surface with the comparison to maximal dose to the brainstem or optic apparatus. We've pooled our data together with a couple Central European groups, namely the group in Augsburg and then Mannheim, to look at this analysis of 54 patients where our 1-year local control rate treating with IORT and brain metastases was 88%. And contemporaneously, the study at Anderson that Ganesh Rao was the senior author on, published in 2017, was at 72% 1-year local control. So these were very promising results for us. Our incidence of radiation necrosis in this patient population was 7%. And we're still following up on this data. We've done some other work looking at the dosimetry and the homogeneity of the dose when it's delivered, and compared the same patients across 3 platforms, nearly single fraction SRS with the gamma knife, single fraction IORT, and then a 3-fraction non-coplanar IMRT planning. The homogeneity indices are calculated by 5 different methods in this particular study. 3-fraction IMRT is superior, having the lowest HI, but for single fraction dose, IORT was better for these resection cavities and dose homogeneity than gamma knife. Whether or not that's going to impact our practice in the future, the jury's still out. How do we follow our patients? We have a registry for the metastatic disease patients because these are not being treated on trial. It's very similar to the registries that are in place for some of the surgically targeted approaches. The first study for us to come out of this REDCap platform registry data is this study, which is still under review, where we looked at the electrocorticography that we've been recording in real time before, during, and after radiation therapy. So we record for 10 to 15 minutes before, actually for the entire duration of the radiotherapy, and then for another 10 minutes after, to see if there's any changes in high frequency oscillations at the cortical surface with direct measurement, and then look at seizure incidence in these patients. We hope to have some more data back on this and published soon. Finally, what are the value benefits here for IORT? From a biological perspective, we don't have the time to get into it, but the RBE is significantly higher than what we're used to in some other modalities, radiotherapy. There's also some evidence from the breast world that there could be something to the radiation-induced bystander effect that exists. The jury's still out on whether or not that exists within the CNS space. I think the true thing that we can really speak to is the elimination of time to initiation, and increasing time for postoperative SRS is a problem for patients. It does affect overall outcome. In my practice, which is rural, treating a catchment area of 1.8 million people spread out over 25,000 square miles in West Virginia, consolidation to a single episode of care is a real value benefit for my patients. Being able to capture them in one episode of care, not have to have them drive back 3 hours in each direction 3 to 4 weeks after surgery. This has been a game changer for a lot of our patients. And then finally, we can eliminate having somebody lay on the table for SRS treatment with the gamma knife for an extra hour, hour and a half to treat a irregularly shaped resection cavity when we can open that up for other patients that haven't undergone surgical resection. So with that, I just conclude with these points that it continues to develop as a treatment option. It could serve as a boost, but we still need to finish that trial. We're down to our last 75 patients for enrollment, so I look forward to that being completed soon. And there may be some advantages over SRS for resection with respect to local control and radiation necrosis, but really long-term use is really what we need to do at this point to kind of figure out where it fits. So with that said, it's a big team, lots of people, multiple continents, and here's my contact information if anybody has any questions about starting a program. Thank you.
All right, Gabriella, are you going to introduce Dr.
Thank you for that beautiful talk. Without further ado, it gives me great pleasure and honor to introduce my esteemed colleague, my collaborator and inspiration behind all the work that was done at Cornell, which we're now continuing at Northwell. Dr. Theodore Schwartz. To many of you, he requires no introduction. He's a world-renowned authority in invasive skull surgery and epilepsy. And in the world of cesium, he's a pioneer who helped me launch this amazing journey. So Dr. Schwartz comes from an incredible pedigree, and his educational background is outstanding. He received his undergraduate degree from Harvard College, his medical degree from Harvard Medical School. Upon graduating medical school, he was trained in neurosurgery at Columbia and has at least 2 postdoc degrees and a fellowship in epilepsy and brain tumor. And I hope I'm not missing more, because Dr. Schwartz's CV did not fit into my 2 hands. It is so thick and extensive. He's currently a David and Ursula Barnes Professor of Minimally Invasive Neurosurgery, Vice Chairman of Clinical Research, Director of Anterior Skull Base and Pituitary Surgery, Director of Epilepsy Surgery and Research Laboratory at Weill Cornell Medical Center. He's a dear colleague and I'd like to say a friend. So I'm giving you a floor, Ted, to present on neurosurgical approaches for implant placement.
Thank you so much, Gabriella. It was a beautiful introduction. Can everyone hear me? My voice is okay. I've been told sometimes my microphone sounds like a chipmunk, so I'm glad that's not happening now. I am going to try to get this set up. Please let me know if it looks okay in presentation mode. Does that look good to everybody?
Yep, that's the
Great.
mode.
Let me just move the images over. I owe a lot of gratitude to Gabriella for getting me involved in brachytherapy. And I'm going to talk about the work we did together. I was charged today with comparing brachytherapy with cesium seeds using the gliocyte device. So I'm going to try to focus on that as best I can. I'm still having a hard time. There we go. So the first question is, why brachytherapy? These are the things I'm going to talk about. What are the pros and cons of gliocyte versus cesium seeds? Talk a little bit about GBMs versus brain mets, and then kind of give you a bottom line take-home message. On the left is Gabriella, who really started the program with me. We did all our work together. I give her an enormous debt of gratitude. I do want to mention Diana Julie O'Brien. She sort of picked up the torch a little later and did some work that I'm also going to present. So I want to give her credit as well. So, we can't cure most malignant brain tumors with surgery alone. Tumor cells clearly infiltrate into the surrounding parenchyma with a cell concentration that decreases with distance. With METs, it's a fairly small distance, right? Those cells only infiltrate 1 millimeter or 2, whereas with GBMs, they go much farther. So we use surgery to try to sterilize our cavity, and that standard of care has traditionally been external beam radiation. But when we delay our treatment after surgery, the cells repopulate. We have abnormally shaped cavities that can make the dose planning challenging. The dose falls off with cell concentration. And so in the case of a permanent implant, the dose is delivered really over weeks and not minutes. So these are the reasons why brachytherapy is useful. Sorry, I skipped a slide. Is that the delivery is immediate. When there's the lowest density of cells, the highest dose is delivered right to the brain, infiltrated with the highest concentration of cells. Let me just, sorry, make sure. Right, so this is the problem. I skipped a slide. I apologize. I just want to go back and make this clear. The problem with external beam radiation is that the delays can go anywhere from 2 to 8 weeks. So the cells grow back. Your cavity is shaped abnormally, which makes dose planning challenging. And the direction of the beams from outward in means that some of the normal brain is getting some radiation therapy. And with brachytherapy, we deliver the dose immediately. There's the lowest density of cells at that moment in time. The highest dose is delivered to the brain, infiltrated with the highest concentration of cells. The dose falls off with cell concentration, which is perfect. And in the case of a permanent implant, the dose is delivered over weeks, not minutes. And so if cells repopulate later, you're still treating them. All right, let's talk about gliocyte. This was a balloon catheter There were 3 sizes, 2, 3, 4 centimeters, double balloon configuration so it wouldn't rupture. Infusion port was attached underneath the skin. We used Iotrex 125, and apparently, it's easy to shield it during the handling of it in the operating room. And this was the ideal dose planning. So when they sell it to you, this is sort of the marketing that they sell you. It looks like a beautiful homogeneous dose, but I'll show you what it looked like in reality and why it was not ideal. So this is some intraoperative images. Here we are, we've resected the cavity. You can already see there's a problem. We've got a round ball going into an abnormally shaped cavity. It doesn't really make any sense. And then you've got this big foreign body underneath the skin that gets closed. And so this is the ideal case on the bottom, right? It's a nice round met, and look how beautifully it conforms. So in this situation, it makes a lot of sense to use a gliocyte. But here's the reality. A lot of the cavities aren't shaped like a round sphere, right? So here's a resection cavity in the middle, and you see the gliocyte balloon in the middle and on the right. It doesn't really fit the cavity, right? So you're delivering all this dose mainly to an empty cavity, and the brain is not always necessarily right there. Here's another example of a big GBM. The resection is very aggressive, but you can see that the margin of your tumor is not really in contact with the balloon. And so who knows what dose everything's actually getting, and it's not really ideally created to do that. So we published a couple papers. Gabriella is the first author on this one, and the second one as well, on using these balloons and how well they worked, and we had some experience with that. But the problem was, as I mentioned, the balloons are not always the same size as your cavity. The dura is left open in one part so the catheter can pass through, which requires a second operation to remove it, increases the risk of infection. I-125 is not the ideal isotope, and your therapy lasts just a couple days, and then you suck out the radioactive material. Cesium is a better dose because it delivers its dose more homogeneously over a longer period of time. So there's not as many hot spots. You don't give as high a dose in the beginning. There's less risk of radiation necrosis. And if a cell doesn't happen to divide in the first 10 days and it divides at 15 days, then you're going to hit it with the cesium. You may not hit it with your I-125. So with cesium, we could line the cavity with seeds. The dose conformality is optimized. The dose is delivered over a couple of weeks, so more cells are targeted. And the lower dose of the seeds gives you fewer hot spots and no need to do a reoperation to remove anything, because it all absorbs on its own, and then the dose goes away. So this was an example of the GBM, big GBM, but you can see how you can literally target the entire margin of your resection cavity with the seeds. And we talk about the gamma tile, that they get placed a centimeter apart. And so it is possible to place these seeds a centimeter apart. And you can see out here, they're basically placed a centimeter apart. And then we would cover it with Surgicel and put some Tisseel so that it wouldn't move by gluing it in place. But these cavities do shrink over time. But this shows you a little bit of what that looks like when they did the dose planning afterwards. But brain metastases, in my opinion, are really the best indication for intraoperative brachytherapy. Surgery alone, we know, gives you a local control rate of about 60%. Whole brain RT brings it up to about 86%. But whole brain RT is not great for your cognitive outcome. You can see that declines in learning and memory much higher with whole brain RT in addition to SRS versus SRS alone. So we now then move to stereotactic radiosurgery, which gives you a local control rate of about 80%. But the problem with stereotactic radiosurgery, and this was a paper that we published when we kind of looked in the real world, and we said, all right, when are we giving our stereotactic radiosurgery to our brain mets? And our local control rate was not that high. And the reason was that a lot of our tumors were not getting radiated for a long time. And if I have LR as local recurrence, it's really local control rate. If you do your SRS within 4 weeks, you have a very good control rate. So only 2.3% would recur. But as that went to 4 to 8 weeks, it went up to 14.5%. And after 8 weeks, it was 50% recurrence rate. And if you wait more than 2 months, you might as well not be treating the patient at all. Actually, the recurrence rate is identical to as if you don't treat the patient at all with radiation therapy. So it just shows you that, yes, SRS can make sense if you give it early, but not everybody is going to get it early. Not everybody can come back to get their stereotactic radiosurgery immediately after your resection. And really 4 weeks was a good cutoff. If you can do it within 4 weeks, your local control rate, progression-free survival, recurrence-free survival was very high. But if you go more than 4 weeks, it goes down dramatically. And in this paper, we showed that once we knew this, it was possible to do a better job. And our time to SRS went down over time. You can see the years, 2012 to 14, 15, 16, 17, 18. It went down to that 30-day mark. But that's an average of 30 days. I mean, some people are getting it in more than 30 days. Also, the volume of your cavity makes a very big difference for stereotactic radiosurgery and its efficacy. And the bigger the volume of the cavity, the less efficacious your stereotactic radiosurgery, because you're targeting this huge volume. So if you have a big volume and the dose, you try to get to the margin, but really stereotactic radiosurgery gives most of its dose to the center. And your 1-year recurrence rate, if you're greater than 3 centimeters, was 40%. Versus 11% if it's less than 3 centimeters. And then there was another study where it was 49% recurrence rate if it was greater than 2 centimeters versus 0% for less than 2 centimeters. So there's some reasons why stereotactic radiosurgery really is not ideal to give to all patients who have brain metastases. Here's just a video showing you how we place those seeds in the cavity. We've resected this brain metastasis and we're putting in our seeds on a string. And you can really target it around the margin of the cavity. I've never used the gamma tile. I'm sure it works very well, but I've had a lot of success with the seeds. And then we cover that with Surgicel to keep it in place. And then we'll fill that cavity at the end with TisSeal so it doesn't shrink so much and to prevent any movement. And that's just fibrin glue. And on the left, you see some cases. This is the dosing of the the cesium seeds. Gabriella already presented this paper. Freedom from progression in the cavity was 100%. We were shocked at how well this worked. This is for upfront new metastases, not recurrent metastases. We had some regional recurrence, and I'll talk to you about that one, but local recurrence was 0. This just shows you pre-op, post-op. You can see the seeds in there. Here are a couple of cases, pre-op, post-op at 1 month, 3 months, 5 months, showing really good control. This was the one failure we had, which is kind of interesting. If you look on the bottom left, the 7th month, you can see the tumor did not recur where we put the seeds. There was probably some spillage of tumor cells. It recurred adjacent to the seeds. So obviously, if you're far away from the seeds aren't going to work. If you done radiosurgery of the cavity, it might not have worked either. But that was the problem with this one failure. So in terms of pros and cons of intraoperative brachytherapy versus stereotactic radiosurgery, you have 1 procedure for brachytherapy versus 2 for stereotactic radiosurgery. Lower cost, more convenient for the patient, deliver the dose early while the cells are continuously dividing. There's less time for tumor repopulation. You're targeting the resection margin as opposed to targeting the center of the cavity with stereotactic radiosurgery. The overall treatment time is lower. The size and shape of the cavity is irrelevant with brachytherapy, whereas it's very relevant for stereotactic radiosurgery, so you have better conformality. And you have no interruption of your systemic therapy. So the patient isn't coming back a month later, taking time off, driving back to get their stereotactic radiosurgery. You could just start systemic therapy soon and keep going. We published with Gabriella on the technique that we did. We published also on larger brain metastases, showing also very, very good control with a larger size. We also published on cost effectiveness, showing that the brachytherapy was cheaper than stereotactic radiosurgery. And then we also published on recurrent brain metastases, showing this as salvage therapy, how well that works. So in conclusion, brachytherapy offers several practical theoretical advantages over any form of external beam radiation therapy. And the cesium seeds deliver several advantages over liquid I-125, which is why we abandoned the gliocyte device. It just really was not ideally suited once we had cesium. So I kept it brief. Thank you very much.
Excellent. Thank you very much. So let's see, right now we should see about answering a few questions. And so first of all, I know that there were a couple ones that were marked for answering live. One quick one for our neurosurgical colleagues is, what is the best glue for fixing cesium-131 in the cavity? Is it fibrin glue? So the TisSeal, is TisSeal the primary thing that's out there?
That's what we've used. You know, there are other glues, Duraseal, Adherus, things like that. I tend not to put those in the brain. I don't even know if they're approved. Those are really meant to be placed on top of the dura to help the dura to seal, whereas TCL will reabsorb. It'll stay there long enough to kind of keep the seeds in place. Eventually, it'll reabsorb fairly quickly. So I'm very comfortable with that. I don't know if other neurosurgeons want to comment.
No, I use Tissio when I need to repair a rent in the ventricle if we end up encountering one and we want to stop CSF egress. So we take a little pledge of gel foam and some Tissio, and it works just fine.
I do that as well.
Seal, gel foam, Duraseal. Yeah, they were asking for them to be named in the chat. That's okay. And then there's the question about the trim planning system. And so, yeah, that's I mean, so we've used Veriseed, we've used Brachyvision. There are MIM programs for catching implanted seeds. There's, I mean, I like anything that does a fine slice CT, a 1 millimeter slice CT. You can use any treatment planning system for these. It's like there's no limitations on that. And so for how you catch the seeds, yep, Brachyvision. Yeah, there's a couple comments on there. Okay, and then I guess, and then going back to that big question that was asked earlier. So there's the issue of re-irradiation. Of what people use for constraints. If there is any, does anyone use the 100 gray in EQD2 as a limit for a volume of the brain? That's one of the ones that's published out there. Are there other constraints that are used in the setting of re-irradiation that people are comfortable using or wish to use?
I'll just comment on what we do in terms of EQD2. It's sort of different than thinking about brachytherapy or radiosurgery type dosing, but for like recurrent gliomas or recurrent meningiomas, for example, we typically do 2 gray fractions, and this is based on a protocol that was developed here by Susan McGovern for re-irradiation of primarily gliomas, and we'll go up to 85 gray to the brainstem to like 1 cc, and then the optics is typically more like 75 to 80, and there's some dependence on whether or not we're using Avastin and things like that, and age and distance or amount of time from prior radiation. But in terms of situations where we might use gamma tile, I mean, I don't feel particularly comfortable very close to the optics or brainstem, certainly not in the radiation setting. So for the re-irradiation setting, so if it's within 5 millimeters, I wouldn't really consider doing the case. But I think other folks on this call have a lot of experience doing this, so I'd be interested to hear what they have to say.
Yeah.
So Ted and I have also had these as the exclusion criteria. The tumor had to be 5 millimeters or beyond the critical structures. Having said that, we just recently did a case very close to the ventricle, but ventricle is not an issue. You patch it up as you had mentioned before. So that used to be an exclusion criterion, but no longer is.
Yeah.
So within our cases, I've had one local progression, and it was in a dural-based met. I think there is something more to dural-based mets, and if I had my choice, small dural-based ones would not be something I treat with IORT. They just the way the spherical applicator really lays in there, it's not perfect. I don't have a flat applicator that I'd put on the dural surface. I even giving a wide margin, I still had a recurrence in that patient. The collaborators we've had in Augsburg have treated patients. They had one failure that then they treated the patient with 30 and 10 and not had any incidents of radiation necrosis after the patient had already received 20 at the surface with a MET. And that's the only real experience we have in recurrence. Our recurrence rates are extremely low for this locally. We have had progressive disease in oligometastatic patients, and I treat all those with SRS with the gamma knife and the single fraction, and we haven't had any incidences of increased radiation necrosis in those patients, even for ones that are within 1.5 centimeters of the original resection.
Quick comment on the dura, the cesium product, and particularly in the string, is great for the dura because you can actually sew it into the dura. And I've done that. You can sew it, around the tumor cavity. I use it mostly for meningiomas that have occurred, atypical meningiomas. Maybe you have a meningioma that's in the sagittal sinus. and you don't want to resect the sinus, you can actually lay it right across the sagittal sinus on either side. It can be very useful for that, and that's one advantage over a round applicator that you would do in the operating.
Yeah, and you can similarly, the gamma tiles can be sort of tucked under the dura if you're concerned about a margin. We do that sometimes, and the meningioma cases, I think that's more heavily employed. But I think the one, we have one case I regret sort of, and it was basically one that we really underestimated the amount of dural invasion, and I probably would have used external beam radiation in that case. But sometimes that's not apparent until you get into the OR and you can realize that the tumor is really invading the dura more than you thought, which can be hard because you only have a certain number of tiles, certain number of seeds, for example.
There was a question, Michael, you saw that some people place, I know the one about seeds migrating in CSF.
Yep, fortunately, that doesn't happen.
Gabriella and I had a case where the seed ended up like in the spine somewhere. We wrote it up as a case report, and the patient was not hurt by it, but it is possible the seeds, you leave them in there, so they're still there. The vicral suture will reabsorb, and those seeds can migrate, right? So they can end up anywhere in the central nervous system, and but it doesn't necessarily mean there's a problem. We haven't had it cause a problem, but they will migrate.
And by the time the vicral has broken down, they're no longer radioactive.
That's
so it's just a material.
Yeah, I think we only had one case like that.
Let's see. And there's also a question about placing one seed at the skull level to avoid tracking. Is that's for the dural tracking, I assume? Is there any, again, for addressing the potential of dural spread, do you ever line the interface up at the dura with additional seeds? I think that's what they're asking.
You mean for a MET, if you're worried about seeding? Is that what they're saying?
I think, I don't know. So the question was, some people place one seed at the skull level to avoid tracking. What is your thought?
I'm not sure what tracking means. Maybe they can clarify.
Yeah, we'll see if they answer, if they put one of them in there. Okay, so we'll wait for that. And so, it's just, so, I mean, one of the big overarching issues always with starting these programs is that we perform these procedures in the inpatient setting. So in a lot of cases, there's the charge bundling, everything gets absorbed into the diagnosis related group or the DRG, which can be a financial barrier for starting the programs, which, as we've seen, clearly have a huge benefit. I mean, these are great treatments with where you get a tremendous benefit for a very low cost. But is there, how have people approached overcoming this barrier at their institutions? I guess starting with Dr. Backham.
I just recommend being a DRG exempt institution. I don't know. That's a great question. I think that the way the finances work and the way money flows matters at any institution. For example, the billing for Gamma Knife is a lot higher than we end up paying for Gamma Tile, but cost savings is also a relevant priority. So there are competing interests. I think that it's kind of interesting at our center because the Gamma Tile charges basically go through neurosurgery. I don't think our group gets any money for this procedure, and we take away post-operative radiosurgery charges. I don't care because I think it all ends up going into the same pot. But so I don't really have any insight into how to navigate that in a more challenging environment. So I'm interested to hear from others.
We had a big issue. Chris, I don't know if you were about to, I don't want to interrupt.
Go ahead.
I was going to say that there's a big irony here with the cost of these seeds that bugs me to no end, which is the cesium seeds cost about 1/10 of the Gamma Tile to order them, right? So in terms of global healthcare costs, we should all be using the cesium seeds on a string. But ironically, the cesium seeds, if you purchase them on a string, I think the Department of Radiation Oncology has to buy them, and they eat the cost of that. So they lose money on it. If you buy the Gamma Tile device, it's bought through the OR and it fits into a DRG. So the hospital actually makes money on it because they get reimbursed for it. So the hospital will make money on the item that costs 10 times as much, and radiation oncology will lose money on the one that costs 1/10. It makes no sense to me, but we've had a hard time wrapping our heads around that.
So on our side, from an investment perspective, the applicators are reusable. And we were lucky in that we had a IORT breast program that kind of laid the groundwork for the initial investment of the device and the applicators. We ended up buying a few smaller applicators for CNS applications, but that was it. Our layout costs. And then as far as hospitalization is concerned, my average length of stay after a craniotomy is 3 days in total, discharged to home. They don't stay a day longer if I've treated them with IORT. The only thing I end up doing is giving them a slightly longer steroid taper, and that's it. So I don't see a lot of impediment in the IORT addition to the practice. Now, with that said, it is like aligning all the planets at times to get all the hands on deck to be able to get the OR time and not be told by anesthesia they don't have anesthesiologists, and have our radiation oncology colleagues and our radiation physicists all present to be able to do it, even though it's not a large time investment, as Dr. Beckham had said. It's got to be at the same, it's got to be at the time. They have to be available. And that's the biggest burden that we run into, is just coordinating schedules. And the only recommendation I could have is have more than just 1 or 2 people available to and credentialed to do it at your institution.
If I can comment, one of the questions addressed by one of the attendees is how much additional time is being taken in the OR with each respective applicator for this procedure. So we can comment on the stranded seeds that, correct me if I'm wrong, it added 10 minutes for a brain metastasis of just about any size. It's additional 10 minutes, maximum 15, but usually 10, 7 to 10, and would add more purely to account for the significance and the size, probably for a sizable meningioma or glioma. Just because it takes more time to implant a higher number of seeds. That's it.
Yeah, just to comment on the time, actually the biggest time waste was sometimes waiting for the radiation oncologist and the physicist to arrive to the operating room. So I would try to call them 20 minutes before I actually needed them to come, because honestly, they're in a different place and they have to come, and they do their best job. It's not a criticism of them, but you can't call them the minute you're ready, because then you have to wait 20 minutes for them to arrive in the operating room and get ready. We quickly would take our gown off, put lead on, which takes 1 minute, honestly, to re-scrub. I would wear eyeglasses that Gabriella got for me for cataract prevention, and a thyroid shield. And then we just finished the closure with that, and gloves, also put on the radioactive gloves. So that would literally take, a couple of minutes. So, and then as Gabriella said, I agree, the placement of the seeds takes 10 minutes. It's very quick.
What about, Chris, would you like to comment? Chris?
So our treatment times, if we use the 1.5 centimeter applicator, it takes 11 minutes to deliver 30 gray at the surface. The largest applicator we use, because of the dose limits to the organs at risk, would be 4 centimeters. That takes 31 minutes to treat 30 gray. For some reason, the smaller applicator, the one that's 3.5, is made of a different material because it was the first generation. So it actually takes 39.2 minutes to deliver 30 gray at the surface. When we went back and looked at our first 5 patients, because we were getting some pushback from OR scheduling, oh, this is going to take extra time, you're wasting time, blah, blah, blah. There was actually no statistical difference between our operative times for those resections for METs as there were with the IORT case added on. And part of the problem was exactly what Ted had mentioned. It was we had everybody there present at the time. We weren't waiting for anything, even other materials related to the resection. So my microscope was ready and draped. My sonopet, if I needed it, was sitting there ready and draped. So we actually had a shorter time in the IORT cases with the additional radiation time than in the non-IORT cases that were contemporary. So it didn't add any time at all. Now, if we shake it out to all the patients we've done, on average, it adds like 18 minutes to the case time.
Mm-hmm. So we're not slowing things too much while you're waiting for us. I mean, we try to have them give us about a 30-minute heads up so we can get over there. And then usually the physicist is already there. That's how we've been trying to do it. So that is one way that we use to try to streamline the scheduling process. But it's always tough. You want to make sure that you block out that time to be available.
I want to do a study of the accuracy of OR heads up times to radiation oncologists for brachy procedures, because the implantation takes 5 to 10 minutes at the longest, but there's great variability in how much heads up we get or if it's accurate. So if I might spend 30 to 45 minutes waiting around, but these are all workflow things that can be discussed with your team as they evolve. But implants are quick.
Yeah. It's something to always remember when you first start these programs. Things are not going to be streamlined and efficient, but once you get the workflow going, once you once you developed your kind of your system with your neurosurgeons, it gets faster and faster and faster.
There was one other question about radiation safety and protection. So with cesium, I can tell you that we tell the patients to keep an arm's length. Remember, I showed the slide, maybe you remember that at 35 and 100 cm distance from the patient, there was negligible amount of radiation, virtually undetectable. And so therefore, especially in the first 2 weeks, the patient is strongly advised to keep pregnant women, children, pets at an arm's length, and preferably for about a month until 90% of the dose is delivered. And the husband and wife who lie in the same bed may separate themselves by a pillow. And that's about it. It's very safe to the personnel, otherwise medical personnel. Patients typically though, we do request a separate room. Radiation officer will come up to the room and place a radiation safety sign. To start a program, you will need nursing education. They will need to get an in-service on radiation safety and handling instructions. There's really nothing special with respect to these patients, but the radiation safety officer will need to get involved in your program.
Let's see. There's a question about the steroid taper following IORT. Is there a standard steroid taper that you use, Dr. Cifarelli?
It's not steroid. I try to keep patients off steroids as quickly as possible. So for a non-IORT case, I'll have somebody with like a 5-day taper post-operatively, just because so many of our patients are going on systemic immune therapy. I will give them 10 to 14 days, depending upon the size of the applicator I use. The larger the applicator, the more steroid I give them. So usually everybody's off in 14 days.
Okay. Let's see. And there was a clarification from the question earlier. It was tumor seeding outside the tumor cavity was what they were asking about. And so so this would be kind of like that edge, that failure at the dural margin. Edge was the question that the attendee was asking. And so is there any point in adding additional seeds kind of up and towards the edge of the cavity to help prevent that dural seeding? That would be very specific to the seed approaches rather than the compact accelerator approaches.
Art, can you say that again?
So that was the question that the attendee had asked was whether you ever place seeds. So in addition to the seeds in the cavity, up where the tumor could be tracking along the dura, do you ever put seeds up there as well to help proactively address tumor seeding?
Yeah, I have not. It could be done for sure. It'd be very easy to do, but I have not done it to date.
Okay. And then there's also a question about for the surgeons about, how useful the lead gown and thyroid shield is when you're doing one of these implants, because the energy is so low. But I think everything adds up, right? So, if you do a lot of these cases, even though the dose is low, it's good to protect yourself. But it's true that it's probably the gloves and the eye shields, since you're in close, maybe the thyroid shield probably matter more than the lead gown.
Yeah, that's probably true, but I'm a better safe than sorry kind of guy when it comes to radiation. So I don't want to I don't want to find out 20 years later, oh, I should have been wearing.
Do you ever use fluoro or CT imaging as well in the operating room?
No.
Okay, so yeah, then because it's definitely a benefit then. I don't use it. So okay. So those are all answered live. Okay. All right. Let's see. I think so. We have hit the time, and so we didn't get a chance to do too many of the cases. I don't know how much time folks here have left. We are starting to lose our attendees. We've lost about 33%. the attendees, but but I think everyone had incorporated a number of nice cases in their talks already, especially the videos, those were great. And so to really kind of show the process, those are particularly helpful. Let's see, so I guess the only other question I would still, just as a general question, it's like if there was the biggest barrier, like the biggest block that you ran into in starting your program, what was it?
For me, it was literally just letting my partners know that it's a accessible, feasible option. And I know in a lot of RVU-based systems, you see some other motivations for trying to get cases done. And, it's not something that we will do in the middle of the night. It's not something that's going to get patients going to get admitted from the ED at 3 o'clock in the morning and be added on 7 o'clock in the morning. And there are some people that feel that that's the best way to handle a minimally symptomatic brain met or newly diagnosed GBM. And that's for me, that was the biggest obstacle, was trying to build a culture in which this was something that was regularly looked at as a potential option.
I'm going to give you a couple. So the first one is, a patient comes into the emergency room with a very large met and needs to go to the OR. You have OR time tomorrow. You don't have OR time in 3 days. You can't get brachytherapy tomorrow. You can get it in 3 days. What do you do as a surgeon? Usually you take the patient to the OR tomorrow. When you have OR time, the patient needs the surgery anyway. To get the seeds can take a day or 2 or 3, and that will eliminate certain patients that might otherwise get the seeds. So not having them on a shelf is one limitation. The second thing is really let's say you have a hospital and a department of radiation oncology that just bought you a gamma knife, and they want to fill the gamma knife with patients. And now you're treating your patients with brachytherapy and not sending them for gamma knife. Politically, that may ruffle some feathers because you're taking volume away from the gamma knife that they just bought for $2 million, whatever they bought it for. So that has to be thought about. And then the last thing is the cost issue, right? So if the Department of Radiation Oncology is paying for the seeds and losing money every time you implant, they may not be so happy for you to be doing all these cases, whereas they may make money if you send them for stereotactic radiosurgery afterwards. So you just have to be thoughtful about the interests of the different parties involved and try to figure out how to make it a win-win.
Yeah. Yeah, really have to make it an institutional approach, and that's why it's good to have a cancer center that oversees things, because then you can make your case for why one thing needs support, another thing doesn't need support. And for these cases, for example, for when we provide physics support or physician support, we document how much that time is, and we actually get reimbursed. And so from the institution, because it's an institutional prerogative, they compensate for the physicist time and things like that, but that required an institutional perspective, not a department level perspective. And so that's something as a brachytherapist, you have to be institutionally minded rather than just departmentally minded. Yeah. All right. Well, any final thoughts on anyone's part? I know we've gone a little bit over time, and I thank you so much for sticking around, and so pass the time to continue answering questions.
Thank you.
Thank you.
Thank you very much. I think it's wonderful, and I think brachytherapy needs to be more on the forefront of every meeting and not forgotten or abandoned. It certainly has its place and application. So.
Yeah, especially such a tool like this. I mean, we need to raise the visibility of CNS brachytherapy, and so because it's a great approach. I mean, it's a really useful tool, and it's keeping the patient in mind. And so really, so thank you all.
Thank you.
Thank you.
Thank
Look
you.
forward to seeing everyone.
Bye-bye.
Bye.